Welcome to Planetary Health First, Mars Next. This is really amazing, and this is a special time tonight. We have Bring a Friend series. This is our third time in, and we have my friend, Christine, here, and she's bringing her friend, Dr. Amy Price. So we are official. We're legit. We are friends. So we're bringing friends, and we're reimagining healthcare together. So, Dr. Amy Price, you're a researchist, and you're at Stanford Medical School. So you're serious, you're legit, and Christine, you're legit from all the years of your experience and all the research and advocacy here. So I'm going to try to get out of the way and let you guys do your stuff
Well,
tonight. And so I
well, first,
really would. Sorry,
I
go ahead.
wanted to correct you really quick because Amy has moved on to an amazing new venture. And so we'll let her talk about that in a second.
Well,
So,
yeah, and the wonderful thing is that there's more than one kind of legitimacy, and like that's what we want to celebrate, because perspectives coming together, it opens it opens all of our fields and our boundaries, and it allows us to think fluidly and to imagine what could happen. And as people start to imagine together, and they grow and they trust each other with ideas, phenomenal things happen beyond what we could ever imagine, like doing all by ourselves. So I'm excited that today I'm with Christina. I'm not all by myself, and I'm with you. And I spent some wonderful years at Stanford, and now I'm at Dartmouth, and applying some of the lessons that I learned there in my new place at Dartmouth. But I have learned that with our communities, that geography doesn't matter much. Wherever I am, people are going to find me, and Christine found me, and uh, because we do, like, we travel, like, we move in and out, we're doing different things, because life isn't static. And even what I found is the very things that I thought would destroy me are the things that have advanced me. And that is like, it is such a gift to realize that no matter where we are in life, um, our vision, our growth, and our personalities, our friendships, they make room for us. And I love that Christine has always made room for me, and I love what she's I love what she's doing with personalized medicine. And Christine, why don't you, like, just say, like, a little bit about the mapping? Like, to me, it's just so magical, because I remember taking genetics, and basically they had us, like, coding the numbers, and we're like, well, what do we actually do with this? And then I remember trying to figure it out from PubMed, that the protein diagrams, and I figured out it had mistakes, and I thought, if this has mistakes, and I don't know what I'm going to do anyway, how can this even be possible? But you found ways. You found
I
ways to
didn't find a
beautiful.
way. It was my network of amazing friends. And Michael, I don't know if I talked to you about what we're doing with my genome. And I think we did. We talked about how we've mapped my genome on the GIS platform and the ArcGIS. Did I tell you that, Michael?
Please tell me more.
So I met an amazing woman during COVID, and her name is Alice Raston, and she runs a company called DNA Compass. And as all of you know, I've been struggling with my diagnoses and where to go. And Alice helped me find a way to map my genome using lat long coordinates onto this map. Right. So we took the Earth's mapping system, or she took the Earth's mapping system, and figured out a way to remove the map layers from the map and then make our genome into coordinates. So by doing that, we were able to then see all of these clusters and mutations based on a map, right? They were highlighted. They were big spots of density mutations in one area. And so looking at it, I mean, it's really confusing. We don't really know what to do with that yet, but we are working with, again, research to the people and really opening up those data sets to see if people can figure some things out. So, and I think really this mapping system is a phenomenal system for us to look at in sharing information and really giving a federated data model to patients globally, to have access to your data, to be able to share that in different layers of your information, and even be able to revoke access to that if we don't agree with what's going on. So it's a phenomenal platform, and it's at dnacompass.com, and I hope I got that right, or DNA Guilds if you want to see an example. But we're going to see what we can do with it, right? And see what researchers out there are able to figure out. And then Amy and I just, everything that we work on really kind of coincides around, down the same path and with the same missions and the same goals. And so, Amy, talk about really what you've worked on. And
So this is really exciting to me, because it's kind of also the genesis of an idea that I had when I had a traumatic brain injury, and I needed to get my brain beyond just normal. And what I did was I took a neuroscience class. I didn't really have the statistics for it, but I practiced the test until I could get in, and then said, sorry, I'm already here. And they took me. And then it said that this modeling platform was without math, but they lied. So I had to learn that too. But then, from then, what I saw was that I could actually map activities on my brain to certain areas of the brain and to certain electrical timings, and then I could attach kind of weights to them, like what was putting stress on the brain, what was helping it learn, what was stopping it from learning. And I learned so much for myself, about how I should start. Should I start with attention? Should I work on something like executive function or planning? What worked when? And so then I just kind of customized that. I built that. We are actually supposed to be working on an eye model. So I did my eye model, and then I just took off on my own tangent. And because it's all the math, it's just the same, whether you use it for an eye, brain, whatever. And then I thought, what would happen if we mapped PET scans, MRIs, and EEGs? And QEEGs, which is like the quantitative aspect. And what we learned is there's fascinating aspects about our neurons and our behavior, and that a lot of what is attributed as emotion or emotional behavior is actually biological. So, for example, and again, why community is so important to me. Did you know that social isolation or being excluded?
We lost your mute.
I'm like, it's always when you get to the good part.
Yeah,
Sorry, I'm not going to touch anything. I thought I was losing you, and I was trying to get you all back.
You're talking about social isolation.
Mm-hmm. Yeah. Okay. So social isolation is mapped and felt in the same way as physical pain, as deep physical pain. So being excluded is no joke, and people with cognitive issues or social issues, they are excluded, and they feel that pain. And what happens is it erodes areas of the brain. It erodes parts of the prefrontal cortex, which is where we reason and where we have our impulse control. It hurts the parts of our memory, and it hurts the amygdala, which is like our fight flight response. So neurons die when we're excluded. So when to exclude people is a form of hate. So I'm just going to put that out there, right? It's
And
a form of murder. You're murdering the brain when you exclude. And so then it's not about what people to include. It's not what people can't do or what they're bad at. It's what can they do, and how can we support them, and what steps can we provide that that make them do it better. So, for example, we've all seen on social media, you see a dog or a cat that's lost their legs, and it's really heartwarming because we see these owners that have built prosthetics for their pets, and you know how much happier their pets are, and their pets live a long life with these harnesses, and they can walk again. Why can't we reharness people? Aren't people as important as pets? And why can't we do it in the areas of thinking and capacity? Because there's more than just moving our physical bodies. It's how can we enable people to show up in life again? And so that's one of the things that I'm looking at. And I've been looking at artificial intelligence as a way to help that, not only in the mapping process, which is what Christine is doing, which is brilliant, and I'm going to learn from her in that, but also in the areas of large language models have all the social intelligence, all the biases, everything that society has. But now they've been trained with like some guardrails to make them polite, and so they don't spew out, things that are hate and that are harmful. And so they are the perfect space for someone with a brain injury to practice getting social graces, to find out, well, what should I say? Because I remember in my brain injury, and even now, like sometimes today, I'll say something and then it starts something. What did I say? I don't understand. Well, I can go back to the large language model and I could say, what did I do? How can I fix it? And then I can take those principles and then I can practice and I can say, I did this time. Can you show me how to do it better? And then if I have a medication or something that I don't understand, I know my clinician isn't really going to have the time that they need to spend with me because they're blocked in those 10 or 15-minute blocks. And I don't want to impose on them or take away another patient's time. But what I can do is I can get as much information beforehand and also after, using the general information from the large language model. And they're going to get better and better. So I don't know how many of you remember when, maybe I'm the only one that's old enough, but when they first brought out digital cameras. And I actually, you do? Oh, awesome. Okay, so the digital cameras, they were like so grainy, but I was excited. And the reason why was I couldn't take a picture to save my life. So if you gave me 6 rolls of film, getting one good picture would be like a miracle. And so it was really like frustrating for me. My husband was like an excellent photographer. He could capture a shot from anywhere, right? But he wasn't seeing it through my eyes. He was seeing it through his eyes, which were great. But just, it wasn't necessarily, I couldn't create the picture. And then I said, well, I'm going to use it anyway because it will give me practice taking pictures. And it did. But what else happened is that now, as technology has improved, that is almost as good as the top cameras that were available back then that cost $50,000, $60,000, $75,000 with the lenses. We're getting that kind of quality. And for speech, it's the same way. I started out because of the disability on a program. I think the program was maybe $1,500 because I had the medical version, and it took hours to train it because it made mistakes, because it was learning. And but then once you got it trained, oh my gosh, it could do so much. It could write for you. It could, and it was like a lifesaver. It allowed me to get through papers, exams, and I would take all my materials. I would record them from the PDF, have them read it back to me, and I would annotate like with this specific program. But now, like my grandkids, they are writing essays using Siri. And not only that, with the large language models, we can do this in multiple languages. We had a program where we brought researchers, clinicians, and patients together. We had them practicing on the large language models, just as they are, nothing fancy and nothing private. And they came back with lesson plans that large language model was able to translate quite well into multiple languages, and then played it back and had an expert like look at it and correct small deficiencies. The things that it saves people that are like us, that don't have those 20-30 million dollar grants. It saves us time, it saves funding, and it helps us to plan better than how we could ever plan alone. And it actually expands us, because instead of just thinking how we think, we're bringing in the whole world and we're saying, what do you think about it? So it's like pre-validating or pre-testing it, because we know from what the large language model brings back. And that's pretty much a picture of what society may bring back as well, except it's going to be a little kinder because it has guardrails. But it helps us.
So, Amy, can I ask you a question? Because,
Sure.
well, first, I want to thank you for bringing up your brain injury too, because I think that's important for you to have gotten over that hump. And I have brain injury myself, which is why the two of us kind of bonded as well, to be able to. I use cognitive behavioral therapy to get there. And so I always think, and I always tell Amy, if two of us with brain damage can understand these things, like, there is no way that no one else in the world can get it, right?
Absolutely.
But I wanted to touch on some of the things, because I do think there's huge benefits in the AI and the LLMs. And I told Michael last time we're looking to build one with me as well. But can you also kind of touch on those harms that may come from an LLM, from the patient side of it, and what some of those could be? Because I also don't want people to think this is the end all be all, right? You and I both know that this is a tool, and we shouldn't depend on it. So could you just kind of
Sure.
talk about it and how the groups that you worked on looked at those things?
Yeah, we did look at those things. So it can, because the model is actually a prediction model. It works by predicting what the next pattern or what the next words might be, and it builds a story around that. So it's only as good as what's being fed into it and what it already has on the inside. So in some senses, you have to be an expert to get expert information from it. So as you feed information out, and this is where the partnership of a patient and a clinician and researcher can be so valuable, because you can bring those three perspectives of expertise together. And then as a team, you can work with that model to assess what's accurate and what would need to be trained, and where the weaknesses of that model are, and how you would augment that or change it. And a second one that I've seen is really disturbing, and that is if you are someone that is not
Typical?
stable. Pardon?
Typical?
Yeah. No, I mean, like, really, like, maybe you're paranoid. Maybe you have like, you're a sociopath, you have narcissistic tendencies, you're in deep depression, you're you're in a bipolar phase where you're way up there, and you feed information into the LLM. The LLM is not necessarily going to diagnose you. It's going to try to please you. So then what happens is then that particular tendency might be magnified because this LLM is um, justifying your error or like the things that are
What
wrong.
you're putting into it.
Yeah,
Yeah.
and
Like a codependency almost.
like exactly like a artificial codependency. Now these things can be trained, but there's always going to be challenges, and I think it's like we can only wait so long for the world to be safe enough. And if we think that, for example, the internet, which has been a great blessing to all of us, but it's also caused harms, a lot of harms. It was basically all the restrictions were taken off because it was the main money makers were pornography and gambling, and so they were very invested in keeping the regulation out. And yet, one way or another, over time, the internet has self-regulated to a large degree, at least as much, pretty much as society. And you can see areas where it hasn't. For example, like in social media, you watching during COVID, for example, the more isolated people were, and the more threatened they felt, you could um, the rigidity and the self-righteousness and the judging, it came out more, and that's dangerous because it can be a really dangerous form of bullying, and um, so there's it's not like we don't have things to overcome, but I also think that there's tremendous promise there, and we need to start using it like in controlled ways. We need to start reporting what we find. So, for example, what if every large language model had, like, those waves that we use for driving? So you can report, there's a police, there's an accident, something's wrong here. What if that could be reported and fed back in real time to all of the large language models, because they'll all be experiencing similar forms of, like of error or things going wrong, or like our traffic jams. And what if at the same time that warnings would go out to anyone that was using the AI, that it seems to be exhibiting unstable actions right now, and this is what they are. And then we could even you could assign like labels, like
Coordinates.
yeah, for what saving, you would be able to track it, right? Like to the source, to the algorithm, uh, with some work, but it's possible. So the same. Go ahead.
Well, no, I want to ask you. We talk a lot about how sometimes that we think that this will self-regulate itself, right? We saw the internet self-regulate, and do you see, like, I mean, we've talked about it so much around patients having agency and access to data. Do you think that having, or could you explain how having that agency over our data could help us self-regulate some of those things?
You can't self-regulate what you don't understand, or what you don't know, or what you don't have exposure to. So until you actually see something, you don't even imagine the need for the need for that regulation. And we see that with people that are like protected in society, for example. They've never gone without a meal. They've had a tutor for everything. Um, they're already bright, and then but they don't really know how the rest of the world like lives, because they have no exposure. And we see many of them have just done kind of like an about face, and they say, oh, like this is the way it is for other people. And I had that with the brain injury, because I never had difficulty thinking before that. Everything was easy for me. And, that has its pitfalls too, because you take failure far too seriously, because it seldom happens. And then when I started to have to work through the brain injury, and I would ask people things like, how many times do you read something before you understand it? And for them, like, it wasn't just once, it was 6 times, 8 times, 10 times. And they got there. It didn't matter if they couldn't get it on the first try, because the ones that kept reading, they got to the finish line. And the thing is that in life, it's the same way. And so we need exposure and mentoring working together, so that we can learn as a world how to direct what has been unleashed. It's too late. Nobody's putting it back. It's already out there. It can be recreated by people fairly easily, and it's out there, and it's making money. So it's never going back in the jar. So now that it's out, how can we get patients and members of the public and end users? How can we get them in there from the very start, so that they have like an understanding in the development, in what's happening with policy? And we see a parallel actually with electronic health records. Physicians that work with patients every day, they weren't the ones that built those electronic health records. And so then when they were built, they caused huge problems, because they took hours of clinicians' time, because they spent time having to find things in records that weren't there at a glance, that they would have to read through. They would have to type things by hand for some security purpose, to satisfy the system. But it didn't work with the doctor-patient relationship. And then even the naming of them, they were called electronic health records. That is like ridiculous. They're electronic billing records. That's what they are. Not electronic medical records.
They're not even your record when you go retrieve it. You're
Exactly.
like, who is this?
Well,
it's
Amy,
like,
I want to say too, my doctor and we just scrapped my medical records, right? It was too much information to go through. So we had to go through 10 pages of my conditions and treatments and mark off what I believed in, what I don't think. And we're trying to adjust that. But we were able to then put a little paragraph that says, this is the things I'm dealing with. And please ignore everything else that has been built up until then. So I think as an industry, I think we all have to realize this is not a medical record. This is a billing statement. I think a lot of us, and I think, Amy, we've talked about this before, a lot of us have diagnoses in our charts for things that we do not have, right? I was
Exactly.
in the hospital for abdominal pain multiple times, and at some point we've got a bill for that, right? So now I have colitis. So
who knew, right?
Right? I don't know. I never saw a doctor for one, but now here's the diagnoses in my charts. And so how do we tackle those when we have all of these companies looking at EMR to pull data from, when that information is not even correct? Even that, Michael, it's not your health record. So can we stop pretending?
It's a storytelling. It's like they're talking about this data. Well, what data? It's like,
and it's someone else's perspective, right? It's not even, if you had my perspective in there, I could have told you I was going to go into heart failure way before the doctors told me that. So how do we fix those errors and not base business models and algorithms off of these things that we don't even know are correct?
Yeah.
And the thing is, and there's so many things like that. So it's not just, I just picked that one out. Like, you could take prior authorization. Who decided that? Was that
Consent.
Insurance.
That's like collaboration? I don't think so. So from how
Denied.
right.
Denied.
And so then like, who decided what a disability is? Did the
Yeah.
patients get to weigh in?
Yeah.
No. So it's like, how functional are you? A
Well,
functional
Amy, it's funny, right? What are the
1/10
qualifications? There's only
functional, but if you ask my wife, useless.
But what do you do, right? When I think aren't the only two qualified disability, like to get on disability, is end stage renal, and I think there's one other, right? What about
Blindness
all
or
of these
something. I don't know.
other conditions, right? Where you do have chronic, lifelong, kind of things. I wanted to ask you guys something. I just recently talked to Gunnar Esiason. He worked with the CF Foundation, and we were talking. And Michael, I shared with you my disability issues and everything last time we talked. But one of the things that we were talking about is the CF community, right? Cystic fibrosis.
They're powerful.
They got this drug passed, and a lot of them are doing great, right? But now these people are being pulled off of disability. No work experience, right? No CV that they can pull out. So as we're finding cures and finding things that work for people, especially those of us who have been dependent on the system for so long, what do you do when you make us better? Like, do you guys, either of you have any thoughts? Because I didn't think about it in that capacity until Gunnar and I had that conversation around these patients being forced to go back to work with no work experience, no education, right? No mentors to even pull them through. So where do these people go?
Well, I mean, I think that we can take parallels from that right here in America. So for years, people that had darker skin, they didn't have the same educational or social opportunities, and so social action was brought in. Things were legislated. Slavery was outlawed, but it took a long time, and there's still a lot of bitterness. The underlying issues are still there, and the thing is so that's where, if you have people in from the ground up, so you're kind of laughing about prior authorization, even though it's no joke, and also about the electronic billing record, because they're examples where there was no collaboration and things went wrong. But if we go back to Nobel-winning economists like Eleanor Ostrom, where basically they gave the assets of the community to the community, and the community governed the assets. And in that space, what they found was the community turned to the experts, and the community had experts within it, but there wasn't a hierarchy of experts. They held things common. And I think that if we hold knowledge common and we respect each other's expertise, and that we aren't the person that's deciding the expertise. So, for example, if I decide and layer and say, well, your expertise is more important than mine, or if anybody decides that, you silence that voice, don't you? And that voice isn't heard, or that voice is rejected. And then you have that whole thing that we were saying, like with the brain, and you see that socially, where judgment starts to suffer and bad choices are made. But if instead we from the beginning said, no, this is all of us, this is we're working together, we don't all understand it, this is what I don't understand, this is what I'd like to see, and we build that from the ground up, then I think that the AI and the mapping and all the things that we're doing today would have a much greater impact, and we could celebrate the brilliance. Like
Mhm.
um, I know that I can just click a button and use an algorithm that was blood, sweat, and tears, and probably somebody's whole life to develop and create and to make work.
Mhm.
So I have to respect that. I respect that. I respect that expertise. But I say, okay, so that's the point. We grow from here. See, that's the whole thing about science. Science changes. Science is not static. Medicine, they say, changes about every 16 to 20 years. So, so the things that were learned are replaced.
Mhm.
And in all areas of science, we progress. There's nothing horrible about proving something wrong if you can prove it better. And then you say, okay, yeah, well, we got this far. Like I look at drawings of by Michelangelo, who also did anatomy, and his idea of how the brain worked and the nervous system, and they're astounding. He was like he was a genius, but he was limited because he only had certain tools. And so the tools that we have today allow us to use that genius and take it
Mhm.
further. And in that, some of those ideas will fall away, and that's okay because they enabled us to get to where we are today.
So Amy, I want to put kind of follow back with what Christine said. I feel like what happens, sadly, the reality of economics when these, if you're basically this medication is very effective, you're able to no longer you no longer qualify on disability. We need to be more clever or creative as a society to crowdsource together. I don't know. I know like Microsoft's done a good job with, or at least promoting it from a PR standpoint with neurodiversity, with some those who have autism or Asperger's or on the spectrum to utilize their skill set. But it seems like we just have such a huge swath of individuals that have such capabilities and that just aren't on paper, right? Like there's gaps. So what could we do as a society to engage them as patient advocates in a way that to me, I think would be, it's just such a lost opportunity. Same thing with the veterans that come back and, whether it be peer-to-peer support. So I'll stop there.
I completely agree with you. And I would say if you want to know how to help someone, you need to ask them. And then you need to really, really listen and unpack what they say and explain your tools in a way that they can, in the way that they can understand them and build on them. And then they'll give you new sets of ideas. So you iterate often, but with the people. So it's the same as um, buying gifts. We've all had gifts that maybe people spent a lot of money on, but we don't actually like them. We'll never use them, and it's like kind of awkward. Has anyone else, ever had that happen? And then you're like, oh, like what do I do now? Like I know they cared, but if only they could have noticed what I did actually like.
Yeah.
If only they could have asked me.
Yeah.
And
And
I think
Amy,
I guess I'm just trying to get at, I know AI is great, but I worry that there's 10 companies that are going to control all AI and everyone's going to be unemployed out looking for a job. That's the scary thing.
I'm, I'm not so worried about that because we've seen that happen over and over in society as technology is coming forward. And I was actually in India. I was very young. We were doing some international missions work, and electronic typewriters had been out for some time, in the um, US and Canada, for example. And they were actually running ads against typewriters, at the evils of electronic typewriters, because they had a lot of, um, you know, the old typewriters to sell. So like it was like economic. It was economic for them as as well. And I think that when they did finally adopt the electric typewriter, when everyone got the internet, so to speak, the world didn't collapse. Where we don't consider enough our resilience as a race, as a people, as like as a world. Now you remember, I spoke at the 25th anniversary of a gynecology obstetrician conference in Europe, and it was so lovely because they brought in one person, and she had this book of women giving birth in so many different countries. And one of the most startling things that I saw was there was one country, and there were at least 4 women to a bed,
Mm.
and they weren't like proper sheets, and it was everything that you could imagine, like in the negative actually. And yet each woman had a cell phone. Each woman had access. They had phones, and the phones were fairly modern. Like, maybe they weren't an iPhone, 15 or 16 or whatever we're on now, but they were, when we even
Mm-hmm.
very earliest models of computers with 2 and 4 megs were enough to send people to the moon and back. And so we underestimate that kind of maybe unintentional leakage of technology and how much it influences and affects all of us. And so, really, in this age, what we need more than anything is we need to be able to communicate with each other, to communicate safely and communicate respectfully, because that opens the door for everything else that will come. Together we can solve whatever comes our way.
So I'm hearing a radical optimistic standpoint from you. You are a radical optimist. I love it.
So who knows?
Aren't we all? Isn't that why we do this?
I don't think
I think if we were pessimists, we would have given up a long time
Mhm.
ago.
and there's no choice. We're alive.
Mm-hmm.
We're alive.
Oh,
So like during COVID, I lost 55 people that were friends, good friends, including my husband, and I stopped counting. And I didn't know how to live because I was looking at death all the time. And I was isolated. We all were. And then at some point, you have to emerge and you decide, well, I'm still alive, so I have to go on from here. I have to figure life out as it is now. And I've seen that happen in my own life. I've had the privilege of, I guess you could call it a privilege, of being involved in where they were in war, in fires, in floods, in hurricanes. And you see such utter devastation. You can't even imagine how you would build back. But as people start to reorganize, that rebuilding comes, and it comes much faster than people think. So for me, I can sit there in the past and I can say nobody was there for me, even though people were there for me, and I probably didn't even recognize them. People were trying. People were trying. They just maybe couldn't get to me. They couldn't get to the situation. So I can sit there like that, or I can say, like, let's build the future. Uh, like, let's move forward. What do I want the world that I live in now, today? What do I want? Where do I want to go from here? Where, like, it's not even like, you can have SMART goals and you can have all those things. You can build what society says they want you to build, but what do you want to build? What's important to you on the inside? What's important to you in relationships and like in progress? So if that, and the empathy, where you don't necessarily, you can't even imagine going through what somebody else has gone through, but you sit there and you see it through their eyes and you do your best. I'm sure you're going to make mistakes. That's okay. So do we want to be there? So why don't we reimagine our own worlds? So if that's radical optimism, I'm in 100%.
Well, thank you for coming in today on Planetary Health First, Mars Next. I'm so glad Christine
What privilege.
got you. Christine, where are you at?
I am actually at a friend of mine's ranch in
No,
Livermore.
I was meaning like.
What do you mean? Where am I? I'm there.
No, I'm sorry. I was just meaning like, what are you at with this conversation? Like, but your friend's ranch, that's cool. Go ahead. I'm sorry.
Yeah, no. At the conversation, I think we're headed for a big change, right? I think that patients are learning, and we have this age, like we've talked about so many times, the age of citizen science that is right here. I have brain damage myself. I didn't graduate from college, but my lived experience, and Amy mentioned mentors, right? I think those are what's important, and I think we have to go back to community, right? I live in Silicon Valley. We went from small community to tech, and we're slowly getting back to community. And so I think I have hope for healthcare in that way, that we learn to kind of integrate all of these different parts of our lives, and then live together. And by far, we not anywhere close yet in the Bay Area, right? But I think we see this community spirit of even our sports teams having, you know, a say in the STEAM programs with our schools, and really a community effort to bring that back, because so many of us were left behind when we grew up here and tech moved in. So I think that there's a huge, you know, I don't know, like connection between those two things. And I really just look forward to it kind of catching up, and us being at a place where we're a little more equal than we have been.
Yeah.
You can see that in wars too. So
That's it.
when people come back, but they have been like they serve together, and they have bonds that no one could break. They've seen things they will never unsee. But you find that those that manage to find a group to stick together and to grow, and even earlier where we've had people that were persecuted and lost their lives, and you find that there's that common thread where along the way there were mentors, there were discoveries, there were open and unexpected doors. And the only responsibility we have is to look for them, and when they present themselves, to walk through them.
Do you guys want to share a little bit of what you're working on? I feel like you guys are up to something really cool.
Go ahead, Christine.
I think there's a lot of conversations being had on the patient side of it that people don't realize are happening. And I think that patients have the same mindset and the same kind of thinking moving forward, and are looking to educate their communities in a way that hasn't been done before, or hasn't proven ROI for anyone else, right? And so I think there's a lot of stuff that's going to happen soon. And I think Amy and I are friends, and we have some great conversations that always kind of spark these interesting things. And we think they'll just lead to more and more projects that are along these same lines.
And
That's
I
what I
guess
hope.
I'm just, I think that the challenge is all these great conversations, they're only just the tip of it on a show like this, right? It's like,
Yeah.
it's in those corridors, it's in the having tea or coffee. And I feel like I'm excited because you guys are up to a lot, and there's some really cool things you're working on. And I'm just so glad that you were able to come on tonight at Planetary Health First, Mars Next. And so we're kind of winding down and saying it as a night. Wish everyone well, and peace be with you, my friends. And until next time,